Hello, I am Dr. Mirela Cernăianu, and I welcome you to the Wellness Optimizing Warrior MD podcast, the WOW MD podcast. I am not your typical wellness coach, and this is not a typical wellness podcast. Here, I'll discuss educational facts about health, hormones, intimacy, anti-aging, and beauty trends, all very hot topics, to empower you to make great choices when it comes to your health and to your body. I want you to go, wow, I did not know that. Or, wow, this is going to make a great difference for me. Our healthcare system is broken and it needs a revolution. You and I can start one today. I am willing to share my knowledge with the world if you're willing to listen. Let's get started. Hello, listener, and welcome back to the episode entitled The Pros and Cons of Having a Period After Menopause. In my previous episode, I talked about the perception of having a period at a certain age and how some patients perceive having a period as being beneficial to them and how some perceive it as extremely inconvenient and wish to avoid it at all costs. And I also reviewed how the medical community perceives on whether or not a period at menopause is necessary, and some doctor perception around vaginal bleeding at menopause when a woman is using hormones. I would like to continue where I left off, and I really want to continue the discussion by starting this episode with the subject of the medical need for progesterone at menopause when we use estrogen. Because again, I get this question a lot. Why do I need progesterone? Can I not take the progesterone? Progesterone makes me bleed. I don't want to take the progesterone. So let's establish the need of why we need to take progesterone and provide you with more information about this topic. Well, first question, why do we need progesterone? Well, it's very, very easy because progesterone is absolutely essential to balance the estrogen that is being introduced in the body as hormone replacement therapy. These two hormones, estrogen and progesterone, go absolutely hand in hand, especially if you still have a uterus. Now, a large majority of physicians who treat menopausal women with estrogen, if the menopausal woman has had a hysterectomy and has had her uterus removed, do not actually recommend progesterone anymore. There is, however, a need for progesterone to balance the growth and proliferating effect of the estrogen on other parts of your body, including the breast. So if you need to know more information about the specific subject of how progesterone balances the estrogen, please go back and look into the 2 episodes that I dedicated to progesterone, explaining the benefits of progesterone for a woman. So let's move on, discuss the real issue at hand here. How much and how long do we actually need the progesterone? How many days a month do we absolutely need to use progesterone while estrogen is being replaced post-menopause? Well, I'm going to answer this question by reminding you that the progesterone our body makes when we were fertile and well-balanced was for 10 to 14 days a month, every month. I discussed why does a woman bleed monthly, so revisit that episode because I explain what happens in a normal menstrual cycle. A woman produces estrogen in the first 2 weeks until ovulation happens. Then once ovulation occurs, and only if ovulation occurs, then the ovary will produce progesterone during the luteal phase. So we have progesterone in the body naturally when we're fertile and everything works well, only during the luteal phase. So how long is this luteal phase? A normal luteal phase will last between 10 and 14 days. If there is no pregnancy, the uterine lining will shed after 14 days of exposure to estrogen and progesterone. You get a period and your cycle starts all over again. So our bodies naturally make progesterone about 10 to 14 days every cycle. We do not make progesterone daily. Our adrenal gland makes very little progesterone, minimal and undetectable as a circulating daily progesterone level. And the adrenal progesterone is not enough to manage and balance the estrogen that is being introduced into the body at menopause as replacement. The progesterone that matters, that balances estrogen, is only the progesterone that comes from our ovaries when our ovaries ovulate. So if there's no ovulation, there will be no progesterone. So we need to introduce progesterone into the body artificially alongside estrogen. And the question I'm posing in this podcast is, do we need to take progesterone every day? Well, in some patients, not in everyone, taking progesterone every day, it's actually a necessity and a benefit. We discussed in the previous episode that the women who have significant pelvic organ pathology like endometriosis, fibroids, they do not want to revisit a monthly period. So taking progesterone on and off, mimicking nature, it's not an option for them. That might not work out in their favor. They will need daily progesterone. They will need to avoid this period. But for the rest of the women who do not have significant pelvic organ pathology, where is the sense in recommending daily progesterone for many years? Do we know the consequences of taking daily progesterone 10 years, 20 years, 25 years? We don't. So I'm going to take a little detour and talk about this subject for a second. The Women's Health Initiative study was launched and the results released in early 2000. And this study was really big in 1990s. It had two arms. One arm used estrogen in the form of an oral pill, not bioidentical. It was equine-derived estrogen from pregnant mares. In other words, and please excuse my bluntness, horse piss was collected, processed, and the horse estrogens from a pregnant mare extracted and synthesized chemically into a pill, which was given to women under the name of Premarin. The second arm of the study used Primpro, which was Premarin combined with medroxyprogesterone acetate, a progestin, a fake synthetic progesterone receptor disruptor. I know it's a mouthful, but go back to my episode that talks about why our body needs progesterone, not progestins, for an explanation about what progestins are. Interestingly enough, coming back to the study that ruined the medical community and the world's view on safety and the value of hormone replacement therapy, interestingly enough, the arm of the study that had all the bad outcomes was the arm that used Primpro. That was Premarin, horse piss estrogen in a pill, combined with medroxyprogesterone acetate, a progestin. The other arm of the study that used Premarin only, let's call it the bad estrogen, right? The horse estrogen, not the bioidentical estrogen, did not have any increased risk of breast cancer, dementia, or cardiovascular increased risk of stroke or heart attack outcomes. All the bad outcomes and the increased risk of cancer that required the early termination of the study occurred in the arm that used progestin. So the conclusion was very obvious and very clear. It should have been obvious and clear to the medical community. Don't use progestins after menopause. However, what came out was something totally different. And it literally dragged estrogen's name into the mud, when in reality, it was simply the progestin added to the estrogen that clearly was the culprit. The arm that used the horse urine chemically synthesized estrogen in the form of a pill did not have all the bad outcomes. The Women's Health Initiative study was debunked by multiple experts and multiple specialists, and many went back and analyzed the data and have since drawn very different conclusions, completely opposed to estrogen is terrible, should not be used after menopause, estrogen will give you cancer, estrogen will give you a stroke and a heart attack, will increase risk of clotting, estrogen will cause dementia, etc. All of these statements are applicable to the use of progestins. So please be aware, if you're taking an oral pill for hormone replacement therapy and it has a progestin in it, you are at risk. So coming back to progesterone, because this is why I took the detour, is progesterone safe to be used daily? I was able to find one study done in 2016 that compared progestin use to bioidentical progesterone after menopause. The conclusion was that breast cancer risk is less with progesterone than the use of the progestin. And this is something that once you understand biochemistry and receptor interactions and a persistent activation risk due to a hormone disruptor use, which is what the progestins are, then obviously jumping to the conclusion that the progestin is bad for us and increases the risk of breast cancer is an absolute no-brainer. But we do not know the long-term progesterone consequences. We do not know if the long-term progesterone used daily for decades is actually safe and will not increase the risk of breast cancer or affect cognitive abilities. All studies that report such consequences are actually listing progestins, not progesterone. And keep in mind, progesterone is a fat-soluble hormone that can cross the blood-brain barrier. Now, I personally believe, coming back to should we take progesterone daily or the minimum amount required to balance the estrogen, I believe that mimicking nature is likely to give us the best result. Nature and God did not make our bodies so that we make progesterone daily during our fertile years. So why would we do something that goes against God's law or nature's law after menopause, which is taking progesterone every day? Why not take progesterone the way nature intended us to, which is estrogen all the time, have progesterone 10 days, 12 days, or 14 days a month, mimicking a normal menstrual cycle. Now, the answer to why not mimic nature is because with mimicking nature, we would cause bleeding. And again, recapping and clarifying why you are bleeding when you take progesterone. There's a lot of misconception that progesterone causes the bleeding. It's the estrogen that you take in the form of a pill, a patch, a cream, or a pellet that makes you bleed, not the progesterone. When you take estrogen as an oral pill, you apply a patch to your skin twice a week or once a week. Use a daily estrogen gel or a daily bioidentical estrogen cream. Or when you have an estrogen pellet inserted, this unique hormone, estradiol, will drive the growth of the uterine lining. So I'm going to use again the same analogy I used in my previous podcast episodes when I discussed how do women bleed and menstruate. Imagine the inside of your uterus as a brick wall. This brick wall is made of bricks. The bricks are the estrogen. There can be no bricks and no wall without estrogen. Now, a brick wall is very unstable if there is no mortar to hold the bricks together. You need that mortar, and the mortar is progesterone. So it makes sense for us to build the wall with estrogen for 14 days, and then we add the mortar, which is progesterone solidifying the wall to protect it and stabilize it. At the end of taking the progesterone, the lining will crash, translating into a period, and this is when the progesterone is stopped in most cases, so that will trigger a bleeding. Now, if you take progesterone daily and you forget to take it for 1 day, sometimes 2, but most of the time, just 1 day of not taking it is enough. The mortar that holds your wall together needs to be reapplied constantly every 24 hours. Otherwise, it will simply crash and you start bleeding. So breakthrough bleeding happens frequently when women take daily progesterone and either take it late, 12 hours, they forgot to take it that night, they take it in the morning, or they left on vacation without it, they forgot it, multiple reasons. And that's something that will happen. And if it happens frequently, then you probably are not a candidate for daily progesterone. Now, again, as I said, many women associate the bleeding with the intake of progesterone, believing that the progesterone makes them bleed. It's not the progesterone that makes the uterus bleed. It's the estrogen. If you don't have working ovaries, if you are postmenopause and you don't use any estrogen, but you decide to use progesterone instead, there will be no bleeding associated with progesterone under normal circumstances because there is no uterine lining built up. There is no estrogen, there's no brick wall, there's no uterine lining. So there will be nothing to bleed. Imagine taking the mortar and spreading it on the bottom of the floor. There will be nothing that will crush or crumble with simply applying the mortar. So there will be no bleeding. Now, this is very important educational information if you're a woman after menopause and taking estrogen and progesterone and experiencing bleeding. So you might wonder, is my bleeding normal? Well, bleeding is only normal if it's when you take progesterone on and off, and you should only bleed past the middle, towards the end of taking the progesterone, or when you stop the progesterone. Any bleeding outside of this scheduled, planned, expected time period, it's actually abnormal and should be reported to your doctor's office immediately. So let's come back to our main topic here. To bleed or not to bleed, should we take progesterone daily all the time for years on end, or take progesterone cyclically, mimicking nature, minimum 10 days, maximum 20 days, and allowing a monthly flow? Well, what are the cons of having a period? Well, there's a few I can think of. Number one, it is inconvenient as a woman. You have to buy pads. You have to expect the bleeding and plan for it so it doesn't catch you unprepared. You have to time it with your travel or events, just like you would be doing when you're on your birth control pill. So it's inconvenient. Number two, it could be physically distressing. We talked about this quite a bit in the previous episode. You could have pain, bloating, cramping. It could be physically distressing to have a period. On top of that, you could have irritation from the tampons or the pads. So having a period could be uncomfortable. And number three, it could cause anemia. If you bleed quite a lot, quite heavily, and if you don't have enough iron in your diet, or you bleed more than a moderate amount. I think that's about it. Inconvenient, physically distressing, and it could cause anemia. Now let's address what are the possible pros. And I started with the cons to get them out of the way, because in my mind, there are significant benefits to having a period after menopause. So what are these benefits that you don't know about and nobody's talking to you about, but I am, and I'd like for you to know them? Number one, having a period monthly after menopause protects your heart. How does it do that? Well, by bleeding monthly, we naturally thin out our blood. Our blood is less viscous and less prone to clotting. A woman's risk for cardiovascular events, a stroke or heart attack, goes up after menopause, not only because a woman loses estrogen, has now more stress, more sleep problems, gains weight, has cravings. Her blood also now becomes more viscous and thicker because she no longer has a period. Therefore, her blood flow throughout the blood vessels is more easily sticky and sluggish. So the platelets can stick to the plaque, cause an event, like a heart attack or a stroke. So bleeding once a month protects your heart, and it's good for your heart. Number two, bleeding monthly after menopause protects your uterine lining. Let's talk about that for a second. How does bleeding once a month protect your lining? Well, by bleeding once a month, imagine the analogy I used earlier with the brick wall. Your brick wall crashes and crumbles and gets eliminated. And in the process of doing that, it allows your uterine lining to shed. So in a logical sense, it's probably less likely to grow a polyp inside your uterus. These polyps like to bleed randomly. It can get very big, and occasionally these polyps, and rarely, they can develop cancer. Also, if you don't shed your lining regularly, you can develop hyperplasia. You can have unexpected breakthrough bleeding. So you can actually have more inconvenience by taking a progesterone daily, and it can actually be much more convenient to allow your lining to shed, and is protective for your uterus. Number 3, why there's a significant advantage to allowing your body to have a period after menopause is information for your doctor. Let me explain. The amount of bleeding and the quality of bleeding that happens once a month will tell the doctor that is directing or managing your hormone replacement therapy how your uterus tolerates the amount of estrogen that is being used. If the estrogen that is used causes your uterus to bleed a lot, either too much in flow, so quantity, or too many days, then that's a warning sign that the amount of estrogen is too much for your uterus and your uterus cannot handle it. So allowing a monthly bleed is very useful information for your doctor, and it keeps you safe. Now, I mentioned before in the previous podcast episode that there are certain medical conditions like fibroids, for example, when the daily progesterone intake might not be the best treatment. One of our newest available medications to treat fibroid pain and bleeding is a progesterone receptor blocker. So fibroids have receptors not just for estrogen, but also for progesterone. Feeding the fibroids daily with estrogen increases the risk of them growing or causing trouble like pain and bleeding, but adding progesterone daily might also make them grow even faster. So perhaps limiting the amount of progesterone that the uterus gets exposed to monthly to just maximum 15 days might be better for women with fibroids than exposing the fibroids to progesterone 30 days a month, 365 days a year with no break. So last but not least, one of the major pros in allowing a monthly period after menopause is preventing breakthrough bleeding. Every time a woman uses hormone therapy and daily progesterone, we do not expect that woman to bleed. Bleeding is not normal and needs to be investigated. The workup for breakthrough bleeding includes a visit to the doctor's office, a transvaginal ultrasound to evaluate your uterine lining. Again, the thinner the better. A possible endometrial biopsy, a possible need for a hysteroscopy, and of course, we need to check the hormone levels. The hysteroscopy is a procedure where the camera is placed inside the uterus to visualize the uterine cavity and determine the cause of bleeding, and at the same time, treat possible causes for bleeding like polyps, thick lining, fibroids that bulge into the uterine cavity and that are accessible, etc. So if we allow for a monthly period, instead of taking progesterone daily, we eliminate the risk of breakthrough bleeding. So women who take progesterone 10 to 12 to 15 days a month, who experience bleeding at the end of the progesterone, that is a planned, scheduled, expected bleeding. Other than normal surveillance of the uterine cavity with an ultrasound, a pelvic exam, an annual pap, there's no need for further workup as long as the findings are all reassuring. However, women that take progesterone daily are prone to breakthrough bleeding, and they breakthrough bleed once, twice, at least 2 to 3 times a year, every year. And it's probably not a good idea to ignore the bleeding episode and consider it simply breakthrough bleeding. It needs to be evaluated. So this evaluation can be expensive, can be painful, and inconvenient. A different way of looking at how should we take the progesterone and how many days we should use it at menopause is what are the actual pros and cons of daily versus cyclical progesterone. We talked about the pros and cons of the bleeding. Let's talk about the pros and cons of daily versus cyclical progesterone or on and off progesterone. What are the pros of daily progesterone? Well, number 1 is better sleep. The majority of patients who choose to take daily progesterone is because it helps their sleep significantly. And this is why progesterone is always taken at bedtime. It is a calming, sedating hormone. Number 2, better mood. Some women feel calmer and less anxious with progesterone, and they prefer to take it on a daily basis. And number 3, avoiding a period. Taking progesterone regularly, daily, at the same time, every day, will avoid vaginal bleeding when we make estrogen or we introduce estrogen from the outside. More likely to be effective when the estrogen is introduced into the body in the same manner consistently than if your estrogen goes up and down, because that will make you more prone to bleed due to the estrogen levels going up and down, not because of the progesterone. So what are the cons, the negatives of taking progesterone daily? Well, there are potential side effects when you take progesterone. Bloating and breast tenderness are very common and significant and can affect a large percentage of women on hormone replacement therapy. Extreme fatigue, tiredness, and grogginess in the morning after taking progesterone at night is a problem for some women, and they don't like the progesterone for that reason. Not taking progesterone daily and limiting it to 10, 12, 14, or 20 days a month will allow for vaginal bleeding. And that's still considered an inconvenience by many women who are done with their periods and would like to leave them behind them at menopause. And another negative is that taking a progesterone daily, but not keeping that commitment, forgetting to take it, just one day, sometimes even being late 12 hours, can cause breakthrough bleeding, prompting necessity for further workup tests, anxiety, medical expenses, and annoyance. So, to conclude, the decision to take progesterone every day, whether a woman wants to avoid a period or because she decides the benefit of sleep is significant, comes with the responsibility of making that commitment to not forget the progesterone. You have to take it daily. You have to take it with you on vacation. You have to make sure you pack it. You want to make sure that you don't lose it, etc. On the other hand, deciding to take progesterone 10 days, 15 days, 20 days a month also implies that the woman needs to make a commitment to taking this progesterone on a monthly basis. She needs to set up a reminder in case she forgets. We tell patients start taking it on the first day of the month, because if you forget or you ignore how essential progesterone is to balance your estrogen, if you use estrogen without progesterone, it will lead to significant side effects and an increased risk for cancer. So, to recap, the pros of having a monthly bleed is protecting our heart, protecting our uterine lining, providing good information, valuable information to the doctor about whether or not the current estrogen therapy is tolerated by the uterus, and last but not least, preventing breakthrough bleeding. So I personally believe in letting the patient choose and giving her the option. As I mentioned before at the beginning of the previous episode, if you suffered all your life from bad periods, there's no need to bring them back. However, the issue that needs to be considered when estrogen and progesterone are administered after menopause, and there is coexistent female organ pathology that preexists menopause, is that menopause and hormone replacement after menopause is not a sprint. It's not something you use for a year or two. It's a marathon. Now, remember, menopause is this term we use. We're just going to draw a line in the sand. We have all the women who still make some estrogen on one side of the line, all women who no longer have any functioning ovaries for at least 12 months on the other line in the sand. Keep in mind, menopause is the rest of your life after your ovaries stopped working. It's not a transition. It is the rest of your life. It is a marathon. Starting this marathon with pre-existent pathology and choosing to use estrogen replacement will obviously require progesterone replacement as well. So I explain it to my patients. When a woman starts menopause and she has zero problems with her pelvic organs, she's just a marathon runner right next to you. If you start menopause with pelvic organ pathology, moderate size to large size fibroids, endometriosis that required surgeries in the past, you have a history of ovarian cysts, you have a history of heavy, painful periods for no reason, you are starting this marathon by carrying a huge backpack during the marathon. This backpack will hold you back significantly and consistently and persistently for the rest of your remaining life while you use hormone therapy. This pre-existing condition will limit the amount of estrogen that could be used to improve the quality of your life and alleviate your symptoms due to estrogen deficiency. It's not unusual for some women to decide to have a hysterectomy after menopause because the estrogen replacement has worsened the pathology that was already there at the start of menopause. So if you find yourself in your late 40s or early 50s requiring an endometrial ablation, or you are diagnosed with uterine fibroids that are pretty large, discuss with your physician the realistic expectation of the longevity of your uterus if after menopause you require estrogen. I found very often in my conversations with patients who are diagnosed with fibroids or severe endometriosis close to menopause, or who have undergone an endometrial ablation close to menopause, the possibility of a hysterectomy was never discussed with them. Now, if you're in your early 40s, you have no fibroids, no obvious endometriosis, you have some adenomyosis, and there's heavy flow, and you're clearly estrogen dominant. If your doctor doesn't know how to treat estrogen dominance or look for the root cause of it, then yes, an endometrial ablation is a good solution. And it's a significant relief from the crazy, heavy periods that some women in their early 40s experience. A lot of women have this very negative view of having a hysterectomy. And I'm going to dedicate an entire podcast episode in the future to this topic. But I want to end here my podcast episode about the pros and cons of having a period with this little tidbit of information about hysterectomy. Having a hysterectomy is no longer the same with what a hysterectomy meant 20 years ago or more. Hysterectomies are now done as an outpatient procedure. They're easily done laparoscopically. They are much safer, and the recovery period is significantly shorter. The surgical skill of the majority of surgeons has evolved because there's now standard of care on how to approach all the uterine, tubal, ovarian pathology, and an abdominal hysterectomy with an open incision, like a cesarean incision, is now very rarely performed. Only when fibroids are absolutely huge and there's no way we can morcellate them due to the patient's age, or they're too large to come out vaginally. So vaginal hysterectomy is also less safer than the assisted laparoscopic approach. So laparoscopy has now become the standard of care, and it's the preferred method to help a woman remove her diseased uterus. Again, I would end this episode here. This is a whole other topic for another time. I would dedicate another podcast episode just to the subject of to do or not to do, or to have or not to have a hysterectomy, when to do it, when to consider it, and when not to do it and avoid it. But I will end now our current episode, and I hope that the pros and cons of having a monthly bleeding on hormones after menopause have resonated with you and have helped you make a decision on what to do and what to choose. As always, I thank you for your patience, for listening, and I really hope you have learned something valuable for your health today. Until I see you again. If you liked the information you heard and you'd like to hear more, please subscribe and follow my podcast. Should you find the content helpful to not just you, but possibly others, please share it and feel free to leave us a review. You are welcome to join the Facebook group, The Warrior Optimizing Wellness MD. I certainly hope that you've heard many things in this podcast that made you go, wow, I did not know that, or wow, I'd like to know more. So keep listening, and I'll keep talking.